So cancer of the esophagus, Barrett's esophagus, risk factor. Barrett esophagus is defined by the presence of intestinal metaplasia. Intestinal metaplasia, that is mucin producing goblet cells in columnar cell line epithelium that replaces the normal squamous epithelium of distal esophagus. The absolute risk to develop adenocarcinoma in a year once thought to be 1 in 100. Now estimated to be 0.12 to 0.33%. Regardless of this revised absolute risk benefit of Barrett's esophagus remains the single most important risk factor for development of esophageal adenocarcinoma with a relative risk of 11.3. Patients with short and long segment Barrett esophagus are at a risk of developing dysplasia and subsequently adenocarcinoma. Polymorphism. So polymorphism near TBX5 and GDF7. TBX5 and GDF7 polymorphism, they are associated with risk of Barrett esophagus. And a genome-wide association study from 10,158 patients with Barrett esophagus and 21,062 control revealed 2 single nucleotide polymorphism previously not identified as associated with Barrett esophagus, RS3072 and RS2701108. And this single nucleotide polymorphism appears to be associated with genes that encode transcription factor involved in thoracic and esophageal development or proteins involved in inflammatory response. Another genome-wide association study evaluation included a meta-analysis of genome-wide association studies of Barrett esophagus and esophageal adenocarcinoma up to Feb 2016, and this study evaluated 6,167 patients with Barrett esophagus and 4,102 patients with esophageal adenocarcinoma as well as 17,159 control from 4 previous genome-wide association studies, and the investigators found that the strongest disease pathway was associated with mesenchymal development and muscle differentiation. So prevalence of Barrett esophagus in general population undergoing endoscopy is approximately 1.5%. And those for reflex symptoms, presence of Barrett's esophagus is 2.3%. And in those without reflex symptoms, it is 1.2%. So in general population, the prevalence is 1.5%. With reflux symptom, prevalence is 2.3%, and without reflux symptoms, prevalence is 1.2%. The utility of screening patients with symptomatic reflux is unproven and unlikely to have a significant impact on reducing death from cancer by 40% of patients with adenocarcinoma of the esophagus have no history of reflux, and less than 5% of the patients undergoing resection for adenocarcinoma were documented to have Barrett esophagus before seeking medical attention for their symptomatic cancer. Despite this, the American Gastroenterological Association, the American College of Gastroenterology, and American Society of Gastroenterology Intestinal Endoscopy recommend selective screening of both the patients with GERD and multiple risk factor for esophageal cancer. Both medical and surgical anti-reflux therapies are effective at reducing or eliminating symptoms of GERD, but no clear-cut evidence exists that either therapy reduces the risk for esophageal adenocarcinoma. So with this surgical or medical management, surely there will be reduction in the symptoms of GERD, but whether it will reduce the esophageal adenocarcinoma risk, that is, we don't have a clear-cut evidence for that. A randomized Department of Veteran Affairs cooperative study of medical and surgical anti-reflux treatment in patients with severe GERD demonstrated superior control of reflux symptoms in the surgical treatment group, but no difference in the medical and surgical therapy in the incidence of esophageal cancer. Overall survival was significantly decreased in surgical treatment as a result of unexpected excess of death from heart disease. So all three US medical societies mentioned previously recommended surveillance endoscopy for patients with diagnosis of Barrett's esophagus. The grade of dysplasia determines the endoscopic interval. Multicenter prospective cohort study from Netherlands demonstrated that endoscopic surveillance identified adenocarcinoma at an earlier stage than the general population, and patients who developed cancer during surveillance and treated endoscopically had similar survival to general population with early stage adenocarcinoma. However, the efficacy of surveillance endoscopy is unclear, and there is no convincing data demonstrating that surveillance prevents cancer or improves life expectancy. So McDonald et al. What did they say? They took 143 patients of Barrett's esophagus of average, and with 4.4 years of surveillance endoscopy, and identify only one patient with asymptomatic esophageal adenocarcinoma. And similar findings were reported from O'Connor et al., McDonald et al., and O'Connor et al. This study suggests that routine surveillance of patients with Barrett esophagus is unlikely to alter the natural history of the disease due to low incidence of adenocarcinoma. Some authors suggest that surgical anti-reflux therapy causes regression of the metaplastic epithelium or interrupts progression for Barrett esophagus to low or high-grade dysplasia, but convincing evidence is lacking. And a prospective randomized trial of medical treatment versus open Nissen's fundoplication in patients with Barrett esophagus with or without low-grade dysplasia showed no statistically significant difference in progression of to dysplasia or adenocarcinoma. Observational studies suggest that the use of acid-suppressive medical therapy, particularly PPI, proton pump inhibitor, may decrease the risk of progression from either high-grade dysplasia to adenocarcinoma. Progression from intestinal metaplasia to dysplasia in Barrett esophagus signifies an unequivocal neoplastic changes associated with the potential for malignant degeneration. Dysplasia is classified as low-grade or high-grade. Any degree of dysplasia warrants endoscopic surveillance. Endoscopy every 6 months for the first year, followed by annual endoscopy is recommended for patients with low-grade dysplasia who do not undergo endoscopic eradication therapy. More frequent screening every 3 months is recommended for those with high-grade dysplasia, if eradication therapy has not been instituted, and the management of high-grade dysplasia is discussed later. Now, the proposed stepwise carcinogenic sequence in which specialized intestinal metaplasia proceeds to low-grade dysplasia, high-grade dysplasia, and frank carcinoma suggests a potential opportunity for chemoprevention to discuss the succession of cancer. So there is one trial, ASPECT trial. So ASPECT trial in the UK, it is a phase 3 randomized study of aspirin and esomeprazole proton pump inhibitor for chemoprevention in Barrett esophagus. ASPECT trial. Evaluated the high and low dose esomeprazole with or without low dose aspirin on progression of Barrett esophagus with composite endpoint of time to all cause mortality, esophageal adenocarcinoma or high-grade dysplasia. More than 2,500 patients were enrolled in this chemopreventive trial with a median follow-up of 8.9 years. High-dose PPI found to be superior to low-dose PPI. High-dose PPI was found to be superior to low-dose PPI in preventing progression to composite endpoint, and the combination of high dose PP and aspirin provided the strongest benefit, and effects were additive in protecting against the composite endpoint. A challenge with endoscopic screening for early stage esophageal cancer or for high risk Barrett's esophagus is compliance. Most patients with Barrett esophagus still diagnosed based on the symptoms, and in a large pragmatic randomized control trial, investigators evaluated a pre-endoscopic screening tool or cytosponge trefoil factor 3. A sponge allows for evaluation of mucosal cell in an outpatient setting. Among 1,750 eligible patients, successfully swallowed a cytosponge, produced a sample, and 231 had positive results and were referred to for endoscopy. And after 12 months of follow-up, 140 patients in the interventional group and 13 patients in the usual care group were diagnosed with Barrett's esophagus. So further, 9 patients with interventional group were diagnosed with dysplasia or stage 1 cancer with the intervention group compared to 1 patient with the usual care group. Together, this data suggests that cytosponge trefoil factor 3 pre-endoscopy screening may better identify patients' need for endoscopy with the aim of identifying patients with early stage disease when intervention can be curative. Thank you.